So, good evening, everyone. Welcome to my ECG interpretation presentation. Let me highlight a few things before I start my presentation. I just would like to tell you that it is very difficult for a non-cardiologist to make a full ECG interpretation using only one lecture. And it might need like a series of lectures to be able to make a full interpretation for the ECG. That's number one. But hopefully today, by the end of this lecture, you will be able to identify the cardiac rhythm, whether normal or abnormal, which is quite important. It's the first step and the most important step in patient management. It's quite important for those who are going to attend the ACLS exam or to renew their license. It's also very important for people who are dealing with critical cases, like those who are dealing with patients in the ER or in the ICU. That's number one. Number two, I would like to tell you that this is not a usual lecture, but this is an interactive lecture. I'm Islam Mahrous. I'm intervention cardiology consultant in As-Salam International Hospital. So throughout the presentation, you will have like multiple choice question, MCQ. So what you have to do is only to visit this website using another mobile or even the same mobile that you are holding now. So either you can scan this barcode or you can visit vivox.app through your browser and then enter this number, which is highlighted by the yellow color, 184-366-595. So if you have a smartphone, you can only scan this barcode and it will direct you directly to the website, or you can write in the browser vivox.app and then enter this ID. I will leave it for a few seconds. So my objective today is to give you some basics about the ECG. You will be able to identify the normal ECG. You can calculate the heart rate, whether the rhythm is regular or irregular, and we will show you how to do it. And finally, you will be able to identify the different cardiac rhythm, whether normal or abnormal. So without any further ado, let me jump into my presentation. We will start with the basics of the ECG. So as you all know that we have what we call the pacemaker. The pacemaker is a dot here in the right atrium, which is firing the first impulse to the heart, and then this point will spread all over the atrium, and this will be represented in the ECG with an upper deflection here called the P wave. So whatever changes happen in the atrium, you will have changes here in the P wave. Then the impulses here will reach to another point between the atrium and the ventricle. Is called AV node. And this AV node is just like a bridge. This bridge allows the passage of the cars from one city to another with a certain speed. So if you are driving very fast, you will be stopped by the speed camera. Or if you drive very slow, so you will lag behind a lot of cars and you will have traffic. So it has a certain speed that allows the impulse to go from the atrium to the ventricle. And we will see after that any abnormality will be reflected here in this segment. It's called the PR. So the delay that comes through the AV node is just represented in the ECG by the PR segment. We will see how later on. Then the impulses is going from this point, which is the AV node, to the rest of the ventricle through these bundles, which is called Purkinje fibers, and then it will be represented in the ECG, but what we call the QRS. And then when the impulse is finished in the ventricle, it will draw what we call the T wave and U wave. So you have always to understand that the normal ECG is having a lot of waves, but the most important wave to discuss today is the P wave, which, as we said before, it's representing the atrium, and then the QRS, which is representing arrival of the impulse to the ventricle, then the T and U wave, which is representing the fade of the impulse in the ventricle. We have two very important intervals. We will discuss this in details in the next slides. PR interval, which is calculated from the beginning of the P until the beginning of the R, and then R to R interval, which is from the R wave until the next R wave, and we will see the significance of all of this, the waves and the intervals in the next slides. But what I'm asking you to do is always to keep this ECG in mind, because if you want to identify something abnormal, you have always to compare with the normal. So this is the normal ECG. If I'm telling you what is the component of the normal ECG, you have always to know that it starts with the P wave, which is representing the impulses coming from the atrium, and then the QRS, which is representing arrival of the impulse to the ventricle, and then the T wave, which is representing leaving the impulse from the ventricle. This is very important. So now you know that we have an ECG. So if you want to make an interpretation for an ECG, you have always to have a scheme in your mind. So if you have a scheme, you will reach to the diagnosis. And this is my scheme. We have always three cards to play with. First of all, we have to know the heart rate, whether it's irregular or irregular. We will know how to calculate it. Then we will see the P wave, how many P waves and P wave is present or not, and what about the PR interval, and then the QRS, is it present or not, the shape of the QRS, and finally the RR interval. We will discuss every one in details, and by playing with these three cards, you will be able eventually to reach to the diagnosis of the cardiac rhythm. So let's start with the heart rate. So before starting with the heart rate, we have always to know the normal range of the heart rate. So if you want to calculate the heart rate, you have always to keep the normal range in your mind. So the normal range is ranging between 60 and 100. So less than 60, we call it bradycardia, like a turtle, or above 100, it's tachycardia, like a cheetah. So how to calculate the heart rate? If you want to calculate the heart rate, it really depends on the rhythm. If the rhythm is regular, we have one way to calculate the heart rate. But if the rhythm is irregular, we have to have another way of calculating the heart rate. I will show you how in the next slide. Let's start with the regular rhythm. If we have a regular rhythm, how to calculate the heart rate? First of all, you have to locate one of the R wave on one of the heavy red line like this. So this one doesn't work. This one also doesn't work. This one can work. And this one definitely can work because this one is located in one of the heavy red lines. Then we will check the next R wave, and then we calculate how many boxes in between. So if we take this one and take the other one, the coming other one, and then we calculate how many boxes we have, 1, 2, 3, and 4 boxes in between. And you have always to remember that we have a fixed number, 300. If we divided this number by the number of boxes, so you can calculate the heart rate in this ECG strip. So 300 divided by 4, so the heart rate in this strip is 75. As simple as that. So again, we locate one of the R wave on the heavy red line as this one, and then we check the next one. Then how many boxes in between? We have 4 boxes, so we divide 300 by 4, so it's 75. And now the question, 75, is it normal? Is it bradycardia or tachycardia? So 75, you have always to remember the range. It ranges between 60 and 100. So 75 is normal. So what about this one? We locate also another R wave on the heavy red line as long as the rhythm is regular. And we will check the next one and we calculate how many boxes in between. In this strip, we have 6 boxes. We have 1, 2, 3, 4, 5, and 6. So we divide 300 by 6. So the heart rate in this ECG is 50. So 50, is it normal? Is it bradycardia or is it tachycardia? Definitely 50, so it's less than 60, which is the lower limit. So this is a bradycardia. Very simple. Another one, we locate another R wave here on the heavy red line. Not the line in between, no, the heavy red line, this one. And we locate the next R wave. Then we calculate how many boxes in between. In this strip, we have 2.5 boxes. So 300 divided by 2.5. So the heart rate here is 120. So is it normal? Is it bradycardia or tachycardia? Definitely this is tachycardia. So now, what if the heart rhythm is irregular? Unfortunately, the method that I just mentioned cannot work if the heart rate is irregular. So we have to find another way. So the way that I'm suggesting to you is to see how many QRS coming in 1 minute, in 60 seconds. But if you want to make an ECG for 60 seconds, you have to use 1.5 meter of the ECG paper. That's nonsense. It doesn't make any sense to make 1.5 meter of paper for each patient in order to calculate the heart rate. So the other way around is to calculate 15 boxes. These 15 boxes will be as equal to 3 seconds. But are we calculating the heart rate in 3 seconds or 60 seconds? We are calculating the heart rate in 60 seconds. So we calculate how many R wave coming in 3 seconds, and then we multiply this by 20, and then we can get the heart rate in 1 minute. I'll just give you an example. In this strip, for example, we have 1, 2, 3, 4, and 5 QRS. This is not in 1 minute, but this is in 3 seconds. So what if we want to know how many QRS in 60 seconds? So we have to multiply 5 by 20. So the heart rate here will be 100. Let's take this an example. First of all, if this strip is regular or irregular, definitely it's not regular, it's irregular. So first method to calculate the heart rate would not work here, and so we have to use the other way. So first of all, we have to locate 15 boxes, which is representing only 3 seconds in the ECG. So we have 1, 2, 3, 4, and 5 QRS in this 3 seconds. So what about in 1 minute or 60 seconds? We multiply 5 by 20, so it's 100. This is the heart rate in this ECG strip. So I'll give you another example of atrial fibrillation. This is a completely irregular strip. So if you want to calculate the heart rate, just take 15 boxes, which is representing 3 seconds, then calculate how many QRS coming here. So 1, 2, 3, 4, 5, 6, 7, 8. This is only in 3 seconds. So in 1 minute, 8 multiplied by 20. So the heart rate in this strip should be 160. So now your turn. So the one who is having any problem, I will leave this screen for 10 seconds in order to scan the code, or you can go to vvox.app and enter please this number 184-366-595. So if you do this, you will be able to find the question and you can answer the MCQ without any problem. And be sure that your name will not be shown, so don't be shy. Just give a trial, give a shot, no problem. We are here to learn the ECG. So that's my first question. When I press enter, you will be able to answer the question, but please look at the presentation first and calculate the heart rate and then go to the website and give your answer. So I'll leave it for a while and then I will start the poll. Now starting, you can give your response. We have 31 people joining. So people now are starting to respond. Only 6 people among 33, so we have all of us has to go to the website. So 63% they got the correct answer, 75. Some of them they said 100, some others said 50, and 0 they said 150. So the correct answer here should be 75, as you can see in the presentation. So I'll give you the explanation. It is the same way. As long as this is a regular strep, so we have to use the first method. How can we use the first method? We locate one R wave on the heavy red line, then we will see the next one, then we calculate how many boxes in between, and then 300 divided by 4, so it's 75. Now we are going to the next question. So if you are ready now, I will start the poll. So we have 42 people now. We have 3 responses. We need everyone to respond. Your name will not come, don't worry. Make any mistake you want, no problem. So only 10 people responded, but it's 150 and 66%, 8% they said 50, and 25% they said 75. So we will see the correct answer now. It's 150. So why? This is a regular rhythm. So we calculate one of the R wave. We check this one. It's in a heavy red line. This is the next one. How many boxes in between is only 2. So 300 divided by 2. So it's 150. Let's take the one more example. Good. Now we have more than 16 people participating. So 50. Excellent, guys. So I have 76% of people, they said 50. And this is the correct answer. So why correct answer? Because this is the QRS on the heavy red line. And this is the next one. How many boxes in between? Let's count. 1, 2, 3, 4, 5, and 6. So 300 divided by 6, it's 50. So this is bradycardia. So now you can know to calculate the heart rate. So what if the heart rate or the rhythm is irregular, like this one? So I tried to make it easy for you. So I draw this box for you, which is representing only 3 seconds. So the QRS that you can count in this box is only can represent 3 seconds. So now we will start the question. Start to respond, please. Excellent, guys. So now many people, they are starting to respond. Excellent. Almost 20 people responded. Good, guys. Oh my goodness, that's the correct answer. So 89% they choose 220, which is correct because this is irregular heart rhythm. So we cannot use the first method. So we have to calculate the heart rate in 3 seconds. Then we multiply by 20. So how many QRS here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. And then if you multiply by 20, so it's 220. So that's the correct answer. This is the explanation. This is tachycardia. So now we know how to calculate the heart rate, whether you have a regular or irregular heart rhythm. Now let's move to the second card, which is the P wave. The P wave, you have always to see whether it's present or absent. Then how many P wave before each QRS, and what about the PR interval? So if you play with this card, you will diagnose a lot of cardiac rhythm problem. So let's go to the P wave. So we have two conditions. Either we have a present P wave or absent P wave. The normal is to have a present P wave, of course. As we said before, the P wave is coming when the impulse is fired from the SA node and spread all over the atrium through these lines until it reaches here. It will be represented here by the P wave, as we said before. So this is the normal shape of the P wave, and it should be present before each QRS and only one P wave, not more than one. So this is the P wave. If you have some strip like this, so this is nothing but sinus normal cardiac rhythm. As I told you before, you have always to keep the sinus rhythm in your mind, and throughout the coming presentation, I will always put the normal rhythm in front of you in order to compare with the abnormal rhythm. So what if the P wave is absent? We have two conditions here. So either the SA node, which is the normal pacemaker of the heart, is sleepy or is diseased, or we might have another point in the heart is now more stronger than the SA node. So either we have the normal pacemaker has a problem, so now it's sleepy, or we have an active point outside of the pacemaker, it's now more stronger than the pacemaker. So we will see the difference now. So if we have an SA node problem, means that the pacemaker of the heart now is diseased. Heart has to find another point which is working as a pacemaker. So the first point, now the pacemaker, normal pacemaker, is black, is dead, is sleepy, and the heart has to find another point. The first point that comes is the AV node, and that's why we call it a nodal rhythm. So what is the difference between the sinus and between the nodal rhythm? Let's see. Because the nodal rhythm is just in the middle between the atrium and the ventricle, so it's firing impulse to the atrium and to the ventricle in the same time. Not like the SA node, which is located here. First it started the impulse through the atrium and then to the ventricle. But because the AV node is just right in the middle, so it will fire the impulse in both directions in the same time. So the P wave will not be shown. Why? Because it will be shown at the same time, like in the QRS. So the QRS is big and it will mask the P wave. That's why we cannot see the P wave in this condition. So this is the nodal rhythm. Why this is a nodal rhythm? Because it's similar to the sinus, exactly like the sinus rhythm, but without a P wave before the QRS. So this is the clue here. If you find an ECG exactly like the sinus rhythm without P wave, so this is nothing but nodal rhythm. So as I told you before, I will always bring the normal to compare with the abnormal. So the up one is the sinus. This is a normal. You can see a very beautiful P wave here. And then this is the nodal. It's exactly similar to the sinus, but without a preceding P wave. So this is the first example of absent P wave. So what if the SA node is diseased? So it's now is black, and the AV node also is black. So the heart has to find another point to be the pacemaker. So the pacemaker here will be in the ventricle. That's why we call this rhythm Ideoventricular Rhythm. So as long as it comes from the ventricle, it will be YQRS. You have always to remember, whenever the impulses is coming from the ventricle, it will be wide. So in this condition, we have no P wave at all. So why? Because the pacemaker is coming from the ventricle, it cannot reach to the atrium, so it's only doing his job here in the ventricle. So we have a YQRS and we have no P wave, and of course we have bradycardia. Why we have bradycardia? Because the pacemaker here is the fastest, followed by the AV node, followed by the ventricle. So this pacemaker, although it is still working as a pacemaker, but by far it is slower than the normal pacemaker. So the clue here will be the following. First of all, no P wave. Second, we have a YQRS. Why wide? Because the pacemaker now is coming from the ventricle, and it should be irregular, and it should be also bradycardia. Why we have a bradycardia, as we said? Because the pacemaker comes from the ventricle is by far slower than the normal pacemaker comes from the atrium. So just compare between the normal and the Ideoventricular rhythm. This is another example of absent P wave. So this is a very beautiful P wave. We don't have any P wave here. Here is narrow QRS. Here we have a wide QRS. This is heart rate is almost 75. This is very bradycardia, as you can see. So what if the heart, the SA node is working normally, and then for a few seconds it stopped to work, then it start to work again. So as if it takes a little nap. It's only few seconds to sleep, not sleeping at all. So what we will have in the ECG, that we have a sinus rhythm, then a flat line. This flat line we call pause. So the SA node, which is the normal pacemaker, it stopped working for a few seconds, should be less than 3 seconds, then it's resume working again. That's why we have another sinus rhythm back again. So what we call this one? We call a sinus pause. So let's see, we have a sinus here, we have a sinus, then we have a flat line. In this flat line, we're supposed to have a 1 QRS here, but because the SA node stopped to work for a while, so that's why we have a flat line. So we call this flat line less than 3 seconds as a sinus pause. This is another example of absent P wave. To compare between a normal sinus rhythm and the sinus pause. How we explain this flat line, that the SA node stop working for less than 3 seconds and then resume working all again. So what if the SA node stop working at all, and then no other pacemaker will start to work? No AV node, no Ideoventricular rhythm, nothing at all. So what we will have? We have only a flat line. So what we call this flat line? Asystole. So no systole, no contraction, no electricity, it's just a flat line. So it's very unique, and you can know by heart. If you see this one, we have to start chest compression immediately. So no P wave, no QRS, just a flat line. So what we call this one is asystole. All what we mentioned now is an example of absent P wave. This is to compare between the normal and asystole. It's very obvious. So the other type is that we have a normal SA node, but we have a more stronger point in the heart which overcome the SA node and became the pacemaker. So it depends, where is this stronger point? Is it in the atrium or in the ventricle? So in the atrium we have 3 types. One we call SVT or supraventricular tachycardia, AF or atrial fibrillation, and flutter. If it comes this strong point from the ventricle, we have 2 types, ventricular tachycardia or ventricular fibrillation. Let's see one by one. So as we said, the SA node is working perfectly, but for a reason or another, we have a stronger point here which is firing impulses stronger and faster than the normal pacemaker. That's why now this is the pacemaker. So what is the difference in the ECG? We will have no P wave, we will have not a QRS, and we have a very fast heart rate, as you can see. So no P wave, not a QRS, it's very regular, and tachycardia. What we call this one? Supraventricular tachycardia, or cardiologists, they abbreviate to SVT. Sometimes we call it AV nodal reentrant tachycardia or junction. The most common term is supraventricular tachycardia. So this is to compare between the normal one and the supraventricular tachycardia. As you can see here, the heart rate is regular. It's very nice, 75. We have a very beautiful P wave. But here we don't have a P wave before. This is a T wave. We don't have a P wave before the QRS, and the heart rate is very tachycardic. Excuse me, because I have one call from the cardiology on call. الو ابراهيم، انا عندي محاضره معلش دلوقتي بقدمها على ECG، معلش ممكن ايه هي بس بسرعه. ماشي. هيماتولوجي. لا نو هيماتولوجي يس. هيماتولوجي يس. ماشي. Excuse me, guy, I'm sorry for that. We had an emergency. So this is to compare between the supraventricular and the sinus rhythm. Now, the next type of having a stronger point than the normal pacemaker is atrial fibrillation or AF. So this is the normal pacemaker, but we have 3-4 points here, firing impulses in a very heart rate, very rapid heart rate. That's why it will overcome the pacemaker, and this will be the pacemaker now. And this is the ECG that we will have. It's called atrial fibrillation. So what you can see here in this ECG, first of all, there is no P wave before HQRS. Number two, it's completely irregular. So AF, we have three important things: no P wave, irregular, and tachycardia. So what is the clue here? No P wave, not a QRS, irregularity, and tachycardia. Just to compare, definitely this is not the same. So we have a normal, regular. You can measure the distance between these two. It's exactly the same like this two, exactly the same like the RR interval here. So this is exactly the same. But if you can measure the distance between each R wave and another, you never find the same distance. So this one is wide, this one is narrow, like that. So this is a regular, no P wave, and not a QRS. So this is atrial fibrillation. And I put this one also to compare between it and the previous one, which is called the supraventricular. So what is the difference between the AF and supraventricular tachycardia, or SVT? So this is completely irregular and this is completely irregular. So no P wave here, no P wave here. Not a QRS, not a QRS, but here it's completely irregular, here is completely irregular. So in AF it's completely irregular, in supraventricular tachycardia it's completely irregular. This is the only difference. So what is the other type? We have the same problem here. We have a stronger focus, but it's not firing impulses in a very rapid heart rate like atrial fibrillation, but less slower. And this is having a very, very unique feature here. The P wave is absent and it's replaced by what we call F wave. If we can see this one, no P wave, but we have a multiple P wave. It's called F wave. So it's exactly like if you have a saw here, a saw tooth. So you have here multiple saw tooth. It's called F wave. This is very pathognomonic. If you see this strip, nothing but atrial flutter. So this is, we call it atrial flutter. So this is to compare between the sinus rhythm and the atrial flutter. It's so simple. So what if the stronger point, it comes from the ventricle, not from the atrium? So as we said before, we have to have a wide QRS. Remember that SCO node is working perfectly, but we have points here which is faster than the SCO node. That's why this one will overcome and will be the pacemaker. So this will be the ECG. We have a wide QRS, we have tachycardia and regular rhythm. So that's why we know that it comes from the ventricle. And why we call it ventricular? Because it's wide. Why we call it tachycardia? Because the heart rate is very fast. So this is a ventricular tachycardia. We have two different types of ventricular tachycardia. They are not all the same. So we have what we call monomorphic and polymorphic. What is the difference? I'll just make a zoom for you. This is the monomorphics. They are all identical. They look the same. And this one is polymorphic. As you can see, they are not looking the same. So we call this one polymorphic or torsade de bois. Example of the monomorphic and polymorphic ventricular tachycardia. If you compare this one to the normal, we have a P wave here, we don't have any P wave here. Number two, we have another QRS, here we have a wide QRS. So we have to stop here. It is coming from the atrium or coming from the ventricle? Definitely from the ventricle. Why Dr. Islam is coming from the ventricle? We have a wide QRS. So if you have a wide QRS, it should come always from the ventricle. Okay? So we have other reasons, but this is for cardiologists. But just remember that if you have a wide QRS, think always about the ventricle. And why we call it tachycardia? Because the heart rate here is almost 150. So it's ventricular tachycardia. So what is the difference between the up strip and the down? This is looking the same, that's why we call monomorphic. Monomorphic is the same shape, or polymorphic means different shape. So the last type is ventricular fibrillation. This is the last type of having an absent P wave. It's the same, the SA node is working perfectly, but we have other pacemaker comes here, but it's firing impulses, you cannot imagine, 400 to 600 beat per minute. So the heart is not really contracting, it's only fibrillating. So as you can see in this strip, there is no P wave, there is no really QRS, but just a wavy line. So this patient is dying, and this is a life-threatening condition. If you are not giving a patient a DC shock in this case, he will die in few minutes. So what are the types of ventricular fibrillation? We have either a coarse ventricular fibrillation, as you can see, or fine ventricular fibrillation. And both of them, they need an emergency DC shock, otherwise the patient is going to die. So there is one thing I have to make it clear here. If you look at the coarse ventricular fibrillation, it's quite clear. You don't have P wave, you don't have a QRS, it's only a wavy line. You know that this patient is dying, give him a DC shock. But the next one is very tricky. Why it's very tricky? Because you have just a line. If you remember, we said before, you have what we call asystole. So sometimes it's not asystole, it's a fine ventricular fibrillation. And there is a big difference in management between asystole, which needs only chest compression, but the fine ventricular fibrillation needs a defibrillation shock, a machine called defibrillation, the same one I showed it to you in the picture, the previous photo, this one. So there is a big difference between asystole and fine ventricular fibrillation. The management is totally different. So now your time is coming. This is a quiz for P wave, a quest for P wave. Again, we will go to the same website. Those who joined us lately, please go to vvox.app and enter this number, or you can scan this code using your smartphone, and it will direct you directly to the pool, and we will start it in a while. So please look at the presentation now, and we will see the strip, and to try to tell me, first of all, whether we have a P wave or not. I will just try to help you here. I'm not going to be so evil. So first of all, we don't have a P wave. So what is the cause of absent P wave here? Is it asystole? Is it a sinus pause? Is it a nodal rhythm? Is it idioventricular rhythm? So just before I started the MCQ, I just want to give you a hint. Asystole means a flat line. Sinus pause, we have normal ECG, then a little bit flat line for a few seconds. Nodal rhythm, as you know, idioventricular, white QRS. So I'll start now. I give you the answer, I guess. So I think many people know the answer now. It's a teaching lecture, not a testing lecture. So 20 people, 21, 22, 24, good. So let's see the correct answer. So excellent. So 60% of you, they said nodal rhythm, which is the correct answer. So asystole, again, guys, means a flat line. So you don't have anything at all. So just a flat line. Sinus pause, that you have a sinus going with a P wave, and then you have a flat line for less than 3 seconds, then again it's normal again. The nodal rhythm, which is, you can see here in the up strip, you have something like, exactly like the normal, but without a P wave. Idioventricular rhythm, we should have a white QRS, and we should have a bradycardia. So the correct answer here should be the nodal rhythm. So just I'll give you a few seconds to look at this strip, and then you can give that shot. We have asystole, sinus pause, nodal rhythm, idioventricular rhythm. So what do you think the cause of this flat line? with no P wave and no QRS. Starting the poll now. So I guess many people is participating. I can tell you that I don't see names here, so don't be shy, give a shot, and no problem. We have 33, 34, good guys. Sinus pose 91%, so I think we started here to succeed. Good guys. So I think this one should be easy for all of you. So we will start the MCQ question. Give you a few seconds. Easy job. Just make me happy, please, with the answer. Excellent, guys. So 96% they said asystole, but few people they said sinus pause. Sinus pause again, guys, means that you have a normal heart, then it stopped only for a few seconds, then it start to work again. But here we can see nothing but a flat line. So the flat line means asystole. Asystole means no systole or no contraction. So the heart stop. So what we have to do for such patient? This is only needs chest compression. Good, guys. So this one I think it's easy. We're gonna start. Is it wide or narrow? I think I gave you the clue now. Time is up. So 88% they said Ideoventricular. Few people they are insisting to say sinus pause. No, that's not sinus pause. Why? Because sinus pause should be a normal ECG, and then we have a flat line for a while, then the normal ECG. That's basically not a normal ECG. We have a wide QRS, and as I told before, wide QRS means ventricular. So if you see idioventricular, just choose number 4. So now, just to give you the answer or to help you, this is irregular or regular. Then we can start the MCQ. Remember that SVT should be very regular. Atrial flutter has a specific and mnemonic locking. So 72% they choose atrial fibrillation, which is the correct answer. So why the atrial fibrillation here is correct answer? Because this is completely irregular and there is no sawtooth as we said before. So we don't have this sawtooth, and the SVT should be very regular, but here if you can look at this strap, it's completely irregular. So I'll start this one you have seen already. So this is supraventricular tachycardia. Take this one please again. Remember the sawtooth the carpenter is using all the time? Is it atrial fibrillation? Is it atrial flutter or SVT? Time is up. 31 people. Good guys. So 83% they choose the atrial flutter, which is the correct answer here, because this is like the sawtooth for the carpenter. As I told you, this is sawtooth. It's F wave, not a P wave. Okay. So let's start this one. Can you see a QRS here, a P wave? Is it monomorphic, polymorphic ventricular tachycardia? Is it coarse VF? Is it fine VF? Let's see. We have 2 seconds left. Time is up. Polymorphic ventricular tachycardia. Guys, you are now is better than me in ECG. So 82%, they said polymorphic tachycardia, which is the correct answer here. So let's take this one. So more people are participating. Good. That's great. So 80% they said monomorphic ventricular tachycardia, number 1, which is the correct answer. So some people they said coarse VF. I will show you the difference in a while. And fine VF is also like a flat line out. I'll show you also in the next slide. So what about this one? Is it monomorphic ventricular tachycardia? Is this a polymorphic VTAC? Is this a coarse VF or fine VF? Just give me the answer. Take the shot. My daughter is asking me about the correct answer. So time is up. My goodness, guys, you are great. So 91% they choose coarse VF, and the one who chose coarse VF in the previous strip, you can see the difference. So this is completely irregularity, just like you remember always this is a wavy line. This is what we call ventricular fibrillation, but coarse VF. So what about this one? This is maybe the last one. Take the shot. Is it monomorphic VTAC, polymorphic, coarse VF, fine VF? I need 100% correct this one. 97% fine VF. Some people they choose the polymorphic VTAC. It's not VTAC because you don't have any QRS here. It's just like a flat line. So if you can take, say for example, this is asystole, I can consider it as asystole, or it's a fine VF. Sometimes it's even difficult for cardiologists to know the difference between them. And sometimes we give a randomly DC shock for the patient. If it was a fine VF, patient will come back. If not, we resume the chest compression. So I can tell you that sometimes it's difficult, not only for nurses or other doctors, but for cardiologists as well. So the correct answer here is fine VF. So we finished now the P wave, and then we go to the PR interval. How many P wave and PR interval? This is quite important. As I told you before, the PR interval is just coming because of the delay in this point, which we call the AV node. It's just like acting like a bridge, as we said before. So if you go across this bridge in a very fast car, you might be catched by, you might be caught by the speed camera. Very slowly, you can make a traffic behind you. So that's why we have to always to know the normal range. We have a normal PR interval and abnormal PR interval. In case of abnormal PR interval, it might be short, it might be long, as we said, it might be variable. So as I need to make it easy for you, the impulses which is coming from the atrium to the ventricle, it might go very fast or it might go very slow. So if it's going very fast, this is abnormal. It's going very slow, it's also abnormal. So what is the normal range? The normal range, as we said, we calculate from the beginning of the P wave until the beginning of the R. This is what we call PR interval. And the normal is from 3 small square to 5 small squares. Okay. So if we have a short one, We call this one pre-excitation. This is out of the scope of this lecture. But if we have a long one or a variable one, we call this one a heart block. What does it mean? Means that the impulse is going from the atrium to the ventricle through the AV node with difficulty. So it's slower than before. So according to the degree of slowing of the impulses passage from the atrium to the ventricle, we have different types of the heart block. So we have first degree, second degree, and third degree. So if it's going very slow, it's called first degree. If it's going, but at the end of the day, all impulses will pass from the atrium to the ventricle. In the second degree AV block, some of the impulses will be able to cross the AV node to the ventricle, and some others will not. In the third degree, all impulses cannot cross from the atrium to the ventricle. I will show you how. So let's discuss now the first degree AV block. As I told you before, all impulses will be able to cross from the atrium to the ventricle, but with a slow fashion. But at the end of the day, all impulses will reach to the ventricle. So what is the difference? It's exactly like the same like sinus, but with prolonged PR interval. As we said before, the normal PR interval should not go above 5 small square. Let's count here. 1, 2, 3, 4, 5, 6, 7.5. So as long as we have P wave followed by QRS, so it's fine. This is not the second degree or third degree. This is the first degree. And why we said first degree? Because the PR interval is prolonged. So it's exactly like the sinus rhythm, but with prolonged P wave. Look at the difference between this strip and this strip. This is having a P wave followed by QRS. Each P wave has a QRS, like this one exactly. But look at the distance here. It's almost 2 square. Look at the distance here. It's small. Here it's very prolonged. So we call this strip first degree AV block. Now, second degree AV block. So now the impulse is going from the atrium to the ventricle in a rather slow fashion. So some impulses will cross, some others will not cross. So those impulses will not cross. It will be only a P wave without QRS after that. We will see how. So we have now more slowing in the AV node, as we can see. So the bridge now is overcrowded and the cars are moving very slow. So some cars will cross from one city to another. Some cars will not be able to do this. So we have two different types of the second degree. Either we have type 1 or type 2. Type 1 is very benign. So as we can see, we have a normal PR interval here. Then started to be gradually prolonged. More prolongation until we have a P wave without QRS. And then we have normal PR, then again gradual prolongation, then P wave without QRS. Why we cannot mention, what we cannot refer this strip as a first degree? Because we have here one QRS didn't cross. Why we say it didn't cross? Because we don't have a QRS after this P wave. It's only P wave without following QRS. So this P wave is stopped at the atrium. So it made the atrial activation without ventricular activation. That's why we don't have a QRS like this. So we have a P wave followed by QRS, P wave, prolonged a little bit, then QRS, P wave, prolonged more with a QRS, then P wave without anything, then again it started to be normal, prolongation, and then it skipped. This is what we call type 1. So that's not a first degree, that's not normal. This is a second degree type 1. Why we are calling it type 1? Because there is a gradual prolongation. What about type 2? It's exactly like the sinus, but all of a sudden we have a normal PR, this is type 1 again, sorry. So I'll give you example of type 2. Normal PR, and then suddenly we have a P wave without QRS. So We never call this one as a first degree, because why we don't call it? Because we have a P wave without following QRS. We have skipped QRS here. So this is not first, it's second. So is it type 1 or type 2? It's type 2. Why type 2? Because we don't have a gradual prolongation. So which one is more serious, type 1 or type 2? Frankly speaking, type 2 is more serious. So if you find something like that without gradual prolongation, you have to take it a little bit more serious. So let's compare between this one and the sinus rhythm. As you can see here, we have a normal PR and it's exactly the same. Look at this one. This is normal PR. This is now gradual prolongation, then skip. So this is type 1. And then this one, normal PR, then P without, and then P without. So this is type 2. Okay. So what about type 3? Type 3, complete heart block, as we refer to, we have no connection at all between the atrium and the ventricle. Means that the impulse in the atrium will remain in the atrium, so the P wave will stay here, never cross here, and the ventricle will work with another pacemaker from the ventricle. So they are working independent. So how can we know the complete heart block? First of all, that the P wave to the P wave is constant, the R wave to the R wave is constant, and the PR interval is variable. As we can see, the PR interval here is very long, it's very short. It doesn't have the same relation like the Mobitz type 2 or the second degree type 2. There is normal PR and then one skipped or two skipped. No, there is no relation at all. You can never have any relation. And one more trick you can know, there is a bradycardia. So to know this one, fix it PR, fix it P to P, fix it R to R, then variable PR, and then bradycardia. So now this is how to compare between complete heart block and the normal. This is the normal. I know that this is the most difficult part of the presentation, but I will give it to you some examples so it will make your life more easier. So here the normal PR interval, here you can find a completely variable PR interval. He is very short, here is very long, here is midway. You can never have any relation between the PR interval in this term. So this is complete heart block. So let's start the quiz. I will try to help you because I know that this is difficult part of the presentation. So, which type of heart block this one? Is it second degree? Is it second degree type 1, type 2? Is it first or third? First of all, before we starting the MCQ, can we call this one as a first degree? If you ask me personally, I would rule it out. Why? Because in the first degree, you should always have a P wave with accompanying R wave. So, but in this strip, you have P wave here without coming QRS. This one also coming without coming QRS. So we can never call this one as a first degree. So then is it a second degree, type 1 or type 2? Is it a third degree? So let's talk about the third degree first. The third degree, you have a completely variable PR interval. So this should be very variable. But if you look at this ECG, the PR interval is the same always here. So we can rule out first degree and we can rule out third degree. So you have to choose between these two. Second degree type 2, second degree type 1. So I will not help you anymore. You have to try to choose the correct answer. We'll start the MCQ now. People, 18 people. Good job, guys. 29, 31. We have 5 seconds left. Time is up. So 62, they said type 2, and 28, they said type 1, and Still 9% they say third degree, but I told you guys that we can rule first and third degree. So those who are choosing third degree, they were not listening. So anyway, let's choose between the first choice and the second one. Is it type 1? Type 1 should have always a gradual prolongation of the PR. This should be short and then gradual prolongation until we have one P wave with a skip QRS. This is not the same here, but we have the same PR wave, PR interval here. It's the same like this one, and then P wave without QRS. Here we have the same PR interval, and then P wave without QRS. So as long as we don't have a gradual prolongation, this is not type 1. This should be type 2, and you have to take it more serious, as I mentioned before. So the correct answer here should be type 2, as you said. So, just take this one. Remember that we have bradycardia. We have no relation between the P and the QRS. So I think I'll give you the answer. Complete isolation between the atrium and the ventricle. Remember, complete. So is it first? Is it second degree? Is it third degree? Good, guys. Third degree heart of blocks on the 91%. Good. So what about this one? So nobody has to choose third degree or type 2 because it was already selected before. So you have only to choose between 2 and 3. Second degree type 1 or first degree heart of block. Time is up. Excellent, guys. So 73% they choose first degree. Why first degree? Because each P wave has an accompanying QRS. There is no skip beat here, but the only difference is the PR interval is prolonged. So all cars are coming to the end of the bridge, so that's why we have a QRS after each P wave, but it's a little bit slow. This is what we refer as first degree heart block. So this is the last one. I think this should be the most easy one. Do we have a first degree or we have to skip the QRS here? P wave without QRS. So never to say first degree. Never to say third degree. Do we have gradual prolongation? Yes, exactly. As you mentioned here in your answer, 83% they choose type 1 because there was a gradual prolongation. The PR interval here is short, gradually prolonged, more prolongation until we have a P wave without accompanying QRS. So this is type 1 second degree AV block. So what about the QRS? This is the last part of my presentation. I'll try to make it so simple. This is the normal. This is the abnormal. I think we talked it before. This is one of the types of absent QRS here. This is another type of absent QRS, as we said before, flat line. So it's either asystole or fine ventricular fibrillation or fine VF. Another type of absent QRS. So we have a wavy line. It's coarse VF or just fine VF. So what is the difference in management of this fine VF and asystole? In fine VF, we have to give the patient a DC shock immediately. In asystole, we have only to give a cardiac compression. What about the QRS shape? As we said, normal shape of the QRS, as we said before. We'll skip this part because we have seen it before. This is the Ideoventricular Rhythm. The pacemaker comes from here and this tachycardia, it's ventricular tachycardia. We have seen this before. Monomorphic and polymorphic, we have seen this before. If this is a pacemaker, it will be also wide because there is another pacemaker. It's not the normal one, the right atrium, but artificial device. and because it's located in the ventricle, it will be wide. And we have like a spike here. This is because of the pacemaker. So what about the QRS shape here? You have a regular one. This is the normal, but sometimes you have irregular heart rate. Like this one, for example, if we have a sinus, and then all of a sudden one point is give only one impulse from the atrium, so it will be exactly the same shape like the sinus, but comes a little bit early. As you can see, the distance between these two, and then comes this one early. Why we call this atrial, premature atrial? Because it has the same shape like the sinus, but comes a little bit early. But what if it has a different shape? One point here is giving only one impulse, while the sinus, the pacemaker is working. So this is the normal pacemaker. Then all of a sudden we have a strange beat here. It's called premature ventricular contraction, or PVCs. This is quite important. So this is a normal until we have here abnormal shape wave, which we call premature ventricular contraction, or PVCs. If we have two, so we call couplet as like a couple. If we have three coming together, we call this triplet. If we have one sinus and one PVCs, we call this one bigeminy. If we have two sinus, then one PVCs, we call this trigeminy. Trigeminy means every third beat we have abnormal beat. So we mentioned this before. If we have and here abnormal point or pacemaker that's firing in a rapid heart rate, this is atrial fibrillation. So this is another example of abnormal rhythm. So again, we will try to take this one very quickly because we are exceeding 1 hour now. So what do you think of this one? Is it premature atrial? Is it premature ventricular, or AF? First of all, AF, no P wave, so we can rule it out. PVCs or PACs? Is it premature atrial contraction or premature ventricular contraction? See the answer. So it's almost 50-50, 56%. This is exactly the same shape like the sinus. That's why we call it premature atrial contraction. So we will see the difference in a while. So what do you think? Oh, sorry. This is AF. I will skip this one because I already, let's take this one. Is it premature atrial contraction? Is it premature ventricular? Is it AF? This should be easy. So look at the last wave here. So 96% they said PVCs or premature ventricular contraction, and this is the correct answer. So what about this one? Is it trigeminy? Is it bigeminy, or couplets? This should be easy. Is it every single one, one single one PVCs, or every two? You can decide. So 59 say bigeminy, and 22 ventricular trigeminy, 18 ventricular couplet. Couplet means two PVCs together, so that's not correct. Trigeminy means two normal and one PVCs, and that's not correct. So the correct answer should be number 2. So what about this one? Two normal, one PVCs. Two normal, one PVC. So every third. So is it bigeminy, trigeminy, or couplets? So the answer is 82% trigeminy. That's correct. So let's take this one. We have here trigeminy, bigeminy, and couplets. Couplets means couple together. Bigeminy, so we have 85% of people, they said couplet. That's correct answer, because they are two together. So I would like at the end of this presentation to thank all of you. The most important rhythm that you can have an exam during the ACLS will be like asystole, ventricular tachycardia, ventricular fibrillation, because they will give you what we call mega code, starting with seeing the rhythm. So if you are not able to know the difference between ventricular fibrillation, ventricular tachycardia, asystole, or atrial fibrillation, you will not be able to deal with the case in the ACLS exam, because your answer will be always based on identifying the cardiac rhythm. So I would like always to thank all of you for attending this long presentation. And hopefully, if anyone wants, I have also other MCQ for all of you. I can send it to you if you want to have more training. And this session was recorded. I can also send it to you as a video. So if you want to know, if you are going to attend the ACLS exam, you have to watch this presentation before. Otherwise, it will be difficult for you to cross the exam, to pass the exam. So I would like always to thank you for attending my presentation. Looking forward to meet you soon in other presentations, inshallah. Thank you so much.